Good morning, everyone. It's 8 o'clock on Sunday, and our IC is on Do You Have Tunnel Vision for Glaucoma? Perimetry made easy for ophthalmologists. So the overview of the topics that we're going to be discussing in this IC is going to be the basics in visual fields, Humphrey and octopus field interpretation, step-by-step approach, understanding progression, and lastly, avoiding the pitfalls in perimetry and masquerades in visual fields. So what is a normal visual field? It's mainly a hill of island in a sea of darkness. So we have heard this a lot. It's the part of the environment that is visible to the steadily fixing eye. Any deviation of the hill from normal is called a visual field defect. So I'll just start my pointer. So if a normal person has superior field of 50 degrees, nasally 60 degrees, inferiorly 70, and temporal 90 degree of field of vision. So few terminologies before we go in depth into interpretation, but these are the terminologies that we'll be commonly using through the talk. So fixation is that part of the visual field corresponding to the fovea. Central field is a central 30 degrees around fixation, and the peripheral field is 30 degrees to the far peripheral. So we use a terminology called threshold. So what does threshold mean? At any given retinal point, the intensity of the stimulus that is perceived 50% of the time that it's presented is called threshold. Anything which is perceived more than 50% is called suprathreshold, and anything that is perceived less than 50% is infrathreshold. A scotoma is a localized defect or depression within the visual field. Gerum scotoma, paracental scotoma, sedal scotoma, all these are examples of a scotoma. An absolute defect is a field defect that persists when the maximum stimulus of the testing apparatus is used. So the blind spot is an absolute defect. A relative defect is a field defect that is present to a weaker stimuli but disappears when a brighter stimuli is shown. So the light intensity is usually expressed in apostolates or ASB units. This is the absolute unit of luminance. So what does this mean? It means that a 10,000 ASB units in Humphrey is the same as a 10,000 in an octopus. But it becomes very cumbersome if we have to write 10,000, 1,000, and 100 in a visual field printout. Hence, decibel is used, which is a relative unit depending on maximum intensity shown by each parameter. So decibel will vary between octopus and Humphrey. So how is this converted? How is an ASB unit converted to a decibel unit? It's mainly the attenuation of light that is expressed in logarithmic units and more commonly tens of the log unit. So if a 10 decibel is used, it's a 1 log unit or 1,000 ASB units light is being shown. If it's a 40 dB, it is 1 ASB unit. So to make this more simpler is this figure, which shows the comparison between the decibel and the apostolates. So if it's a 10,000 apostolates units, which is being shown by the perimetry, it will be mainly 0 decibels. That means it's the maximum light that the perimeter can show. If it is 1 apostolates, that is, it has maximum attenuation of light, or it is 40 decibels. It's the dimmest light. So how does this translate clinically? So if there's a high dB value that you see on a printout in the raw data, it means the attenuation of light stimulus, which is projecting. There's a low intensity of the light stimulus. If the retina is responding to this low intensity of light stimulus, it means it has high retinal sensitivity. So the entire purpose of doing a visual field testing is to find out if there's a decrease in retinal sensitivity or not. So there are 3 main points that we look at. The first is the degree of decrease in retinal threshold. This is mainly by the dB value. Second is the location of this decrease of retinal threshold. This can be in the arcuate, around the blind spots, central. The third is the degree of fall of retinal sensitivity if this is statistically abnormal. So this is mainly by the p-value. So in the stimulus size, the most commonly used stimulus is size 3. So for each size increment, it equals to a 2-fold increase in diameter and a 4-fold increase in area. So if the patient is not able to see on a size 3, you can always increase it up to size 4 and do the perimetry. But only size 3 has the normative data. Stimulus the duration of the stimulus presentation in a Humphrey is 200 millisecond and in an octopus is 100 millisecond. So this is done so that it ensures that It maximizes the temporal summation while minimizing the patient's attempts to look at the target. So visual field testing mainly comprises of two components. First is where do we test? This is the point pattern. And the other is how do we test, which is the testing strategy. So the initial ones which came out was the standard full threshold strategy and the fast pack. Later on, SITA Standard, SITA Fast, and SITA Faster, which is the latest. So why are there so many strategies which have been developed? So the initial one, that's the Humphrey full threshold, it used to take at least 14 minutes per eye. As the newer strategies came out, the latest being the SITA Fast and Faster, SITA Fast takes around 3 minutes per eye and SITA Faster takes around 1.5 to 2 minutes. So when you switch from an older full threshold to SITA strategies, it reduces the time. So this is especially beneficial for older patients and in advanced glaucomas. So how is this threshold determined? It's mainly by the 4-2 bracketing strategy. So this is mainly by the machine shows a bright light and every 4 decibel steps decrease until the stimulus is not seen. Once it's not seen, it again increases by 2 decibel steps until it is seen. It takes an average of these two to get the threshold. In the fast pack, it uses the 3 dB steps. So SITA, or the Swedish Interactive Threshold Algorithm. This is fast. This testing time is much lesser, mainly because it uses a complex mathematical model to estimate the threshold values for each point based on the responses to stimuli at that given point and the surrounding points as well. However, it does full threshold testing for 4 points, that is 1 point in each quadrant. So I spoke about the SITA Faster, which is the the latest strategy. It takes only 1.5 to 2 minutes. This is mainly because it uses the age-matched threshold values. Also, it uses the SITA Fast normative data. There are other points which will be discussed in the subsequent lectures. Coming to the point patterns, the initial point patterns which was used was the -1 point pattern. And now the ones which we use now is the -2 point pattern. So how are these two different? -1 point pattern has points on the vertical and the horizontal meridian. If we take an example of 30-1 point pattern, it still has a 6-degree distance between the 2 points. However, because there are points on the horizontal and vertical, the bare area, that's the area where there are no points, is around 6-degree bare area. In a -2 point pattern, the distance between each point is still 6 degrees itself, but there are no points on the horizontal and the vertical meridian. Because of this, the degree around the fixation where there are no points being tested, the bare area, is only 3 degrees. So the 30-2 point pattern has 30 degrees around fixation. There's 76 total points. The 24-2 point pattern, there are 24 degrees around fixation. It removes the outermost points in the periphery of the 30-2 other than the nasal points. And the total points tested is 54 total points. As we discussed, there are no points on the horizontal and vertical. There's 6 degrees between each point, and the bare area around fixation is 3 degrees. These 2 point patterns are mainly used in suspected or in established cases of glaucoma. The latest point pattern being the 24-2C, which is there in SITA Faster, it uses 10 additional points around fixation, around the 10 degrees. This is because few studies have shown that even in early glaucoma, it's advisable to test points around the central 10 degrees because it can detect early field effects. However, 24-2C cannot replace the 10-2 point pattern. 10-2 point pattern has 10 degree around fixation with a 68 total points. The macular point pattern has 3 degree around fixation with a 16 total points. Again, there are no points on the horizontal and vertical meridian. There are 2 degrees between the points. There's 1 degree bare area around the fixation. So these 2 point patterns are mainly used in advanced cases of glaucoma. So now that we know the basics of the field, we will move on to the next topic, which is step-by-step interpretation of visual field, printout by Dr. Zia.